All right, good evening. In the interest of time, we're gonna start. This is the third part of our heart failure lecture. Um, this is heart failure with reduced ejection fraction. Um, the first session we did definition for heart failure with reduced ejection fraction. We went into epidemiology and then we went into grading and classification. The second lecture, we essentially look at biomarkers, and as we pointed out, these biomarkers help to make the diagnosis, and they help also in prognostication. Um, if you remember or recall, the biomarkers are related to myocardial stress injury, so you can categorize them related to myocardial stress injury, neurohormonal activation, remodeling, and comorbidities. Um, we look at BNP, which is the one that is used clinically um, quite extensively at present. And the BNP is related to myocardial stress and injury. It results from LV stretching. And we talk about the two BNP related biomarkers is the BNP itself and the NT-proBNP. And these are affected by age somewhat. So when you get a BNP or an NT-proBNP, you have to look at the patient age because the older one get, the higher is the level. And we went into the BNP in details, and one of the things that stood out was the negative predictive value of the BNP was very high. What we're saying is that if the BNP is pretty low, if you get a BNP of say 30 nanograms per deciliter, then it almost exclude heart failure. So the negative predictive value is a very high number. It's very significant. But there are other things that can affect the BNP and the NT-proBNP, and we went into those. Renal function was one. Again, age, if patient is critically ill. Other markers, we talk about troponin, and of course, not only we use troponin as a marker with heart failure with reduced ejection fraction, but it can also tip you off if the heart failure is due to an acute myocardial infarction. You can make that assessment. We look at some not so popular biomarkers related to neurohormonal activation, the so-called okay. So um, not so popular biomarkers related to neurohormonal activation. We talk about the MR pro ADM, which is the mid-regional pro adrenomedulin. Not very common, and also the copeptin. These are biomarkers related to myocardial, to neurohormonal activation. So if you see it, usually reference labs will do these, not your regular lab. And then we look at biomarkers related to myocardial remodeling, such as the SD2 gene and the galectin 3. So as we had mentioned before, the ST2 gene is very, very sensitive. It's one of the best markers, but because it's not standardized, we don't use it um, much until it is standardized and it is readily available. We're not using it. Um, And then comorbidities. When one have heart failure with reduced ejection fractions, you commonly see other organs being affected because of poor perfusion, and the kidneys, the liver, and the hematologic system are systems that are commonly affected. And we look at a few of the biomarkers related to the renal function or renal dysfunction, the NGAL, Cayman, the NAG. So, you don't have to memorize those, but know that there are markers that will tell you if the kidneys are involved in the process or the liver hematologic system as well. All right, so we this week's lecture, we're gonna just go over history and physical uh, examination. And most of you guys know how to take a good physical, good history and do a good physical. However, you'll be surprised how many heart failure patients are missed because it's not done. Okay? Not everybody who presents with shortness of breath have asthma. So don't fall in that trap and just giving them an inhaler and walk away. This is where a good history and a good physical comes in. You have to sit down with the patient, find out exactly what's happening. In the history, you need to find out how long they've been short of breath. And is this shortness of breath with exertion or is it at rest? You have to find out if the patient is orthopneic. When we say orthopneic, that is, are they propping themselves up? And once you start asking these questions, you're going to get good answers. Patient will tell you for the last 2 weeks, I've been sleeping, sitting up in my chair. But if you don't ask these questions, you're not gonna get the answers. Okay, so orthopnea, okay, very important. Patient is using 2, 3, 4 pillows, or if it's pretty bad, they're sleeping in the living room in the chair. The other thing is P&D. You have to ask a question. You go to bed, you're asleep, you get up a few hours later, sit up in bed to breathe. Patient will divulge those information. So good history is important. Okay, so dyspnea. So whenever the heart is involved in any disease process, dyspnea, shortness of breath, is going to be a prominent feature. Okay, so is it exertional? So when you have mild heart disease, it will start with exertional dyspnea. The patient have to exert themselves in order for the shortness of breath to become apparent. When it gets real bad, then they'll have shortness of breath at rest. Okay? And remember, the New York Heart Association classification deals with all of this, how symptomatic the patient is. Orthopnea, as we mentioned before, breathlessness on lying flat. Patients will tell they use multiple pillows or they sleep sitting up in a chair. Then we have paroxysmal nocturnal dyspnea. That is breathlessness after several hours of sleep. They go to bed and they're asleep. All of a sudden, they have to sit up to breathe. And the reason for that is when the fluid, remember, when they're up and about during the day, there's a lot of fluid in the interstitial space. Once they become recumbent and they're lying down, a lot of that fluid gets back into the vascular system and it floods the heart and the lungs. And that is why it's after several hours of sleep, they get up and they're short of breath. Tachypnea, that is increased rate of breathing. So there'll be someone sitting beside you and you can count how rapid the breathing is. So good history will lead you in the right direction all the time. Then when you examine the patient, okay, take your time. you know, the lungs will give you a lot of positive findings. So, you know, tachypnea, increased rate of breathing, uh, rales or crackles, okay? Uh, and once you're a little bit experienced, then you can listen to these rales or crackle, and you can sometimes you can tell whether it's a lung pathology or it's a secondary uh, lung pathology from the heart. Uh, Sometimes pulmonary fibrosis can throw you off your tracks because patients with pulmonary fibrosis will have crackles, and you know, so good history and put it together. Don't just take one portion of the history and run with it. Combine everything. Fatigue, because of the poor cardiac output, these patients become fatigued easily, and exercise intolerance. So that's one thing they tell you. They're tired easily. They can't do anything. You know, they have no ambition. So they're gonna you'll get that history from them. Cold extremities, again, because of poor uh, reduced cardiac output. Confusion, decreased brain perfusion. And if we're talking about heart failure with reduced ejection fraction, a lot of these patients are going to have an enlarged heart. So not all, but a lot of these patients are going to have an enlarged heart. So when you examine the heart is going to examine large. So the apical beat, or the PMI, point of maximum intensity, is going to be laterally and sometimes laterally and inferiorly displaced, indicating that the heart is enlarged. And you might hear murmur related to mitral regurgitation. So you have to know what's a mitral regurgitant murmur is. You know, again, it's an holosystolic murmur at the apex, which radiates to the axilla. So you have to be clear on that. Okay, holosystolic murmur, heard best at the apex and radiates to the axilla. That's your mitral regurgitant murmur. If they have tricuspid regurgitation, then that's a holosystolic murmur, or best at the left sternal border, which increases in intensity with inspiration. Um, and if they have aortic insufficiency, aortic insufficiency is a blowing diastolic murmur, and you'll hear that along the left sternal border. And it will increase in intensity with expiration. So again, your right-sided murmurs and sounds are going to increase with inspiration, and the left-sided murmurs and sounds going to increase with expiration. So there's some. All right. And a lot of your patients who are in heart failure are going to have a S3 gallop, a so-called gallop rhythm. So if you hear that, then it helps to make the diagnosis. And we went over the murmurs. Some of your patients, if they have aortic stenosis, so remember your aortic stenotic murmur, okay? It's an ejection systolic murmur heard at the base and the left sternal border, and it radiates to the neck, okay? So they might say it's ejection systolic murmur or a diamond-shaped murmur. So you have to know what, these different valvular pathology, what the murmur sounds like, how to describe the murmur. All right. Again, if there is pulmonary hypertension, then you're going to get ascites, you're going to get hepatomegaly, you're going to get edema of the lower extremity or the sacral area, and you get an elevated JVP. So these are all features of right-sided failure, but I've seen a lot of clinicians will get to pedal edema, they'll get ascites, hepatomegaly, and they just go on the right-sided heart failure. Remember, the most common cause for right-sided heart failure is left-sided heart failure. So you have to make sure that the patient does not have left-sided heart failure. Okay? So the reason why you're going to get your edema, your ascites, your hepatomegaly, and elevated JVP is because you have elevated pulmonary pressures. And that leads to a backup of the blood all the way back to the legs. Okay, nocturia, again, for the same reason, in the recumbent position, the fluid from the interstitial space moves into the vascular space and you get increased renal perfusion. These patients get up quite frequent during the night to pee. So nocturia. All right. You have to, once you take your history, you do your classic physical examination, you need to know what to do with it. Okay, so we put, and I'm going to go over this classification or this system because you have to know it, get familiar with it. When we have these numbers up top is class. So whenever we doing a test, or if we're going to prescribe any medicine, we use a classification system where we class it 1, 2, and 3. Class 1 and class 2, you should do the test or you should prescribe the medicine. It can be a malpractice situation if you don't. If the patient have a class 1 indication for anything and it's not done, that can be a malpractice situation. So we classify either tests or whatever into class 1, class 2, and we divide class 2 into class 2A, class 2B, and then we have class 3. Class 3 is contraindicated. You should not do it. It does not provide benefit, or it may cause harm to the patient. So what we're saying here, a thorough history and physical examination should be obtained and performed in patients presenting with heart failure to identify cardiac and non-cardiac disorders or behaviors that might cause or accelerate the development of progressive heart failure. So basically, a thorough history and physical examination is a class 1 indication. Okay, so again, it should be done and it have to be done. If it's not done, then it's a malpractice situation there. Okay, then the next case, okay, in patients with idiopathic dilated cardiomyopathy. So these are patients with heart failure with reduced ejection fraction, and we basically don't know the cause. Okay, we don't know the cause. They're saying a 3-generational family history should be obtained to aid in establishing the diagnosis of familial dilated cardiomyopathy. So you can have heart failure that runs in the family, and you have to do a 3-generational family history to determine if this is so. Again, that's a class 1 indication. Okay, it has to be done. Okay, the other statement is volume status and vital signs should be assessed at each patient encounter. Every time you see the patient, you need to do vital signs, heart rate, blood pressure. Okay. This includes serial assessment of weight. So you have to weigh the patient as well as to estimate the jugular venous pressure and the presence of peripheral edema or orthopnea. Okay. So it's a class 1 indication. Okay. Again, so we divide usually divide whether it's medication you're going to prescribe for the patient, a procedure for the patient, or anything you do for the patient, we give it a class. It has a class. Class one is strongly, well, class one should be done. Okay? Class one, anything that has a class one indication should be done. Class two is divided into 2A and 2B. So, it just can be done as well as you might not want to do it. Class three is contraindicated, not beneficial. Okay, and then you see there are some letters here, and these letters are what we call the level of evidence. Level of evidence. So, if it has a class, and the level of evidence is A, B, and C. So, and it just goes basically the amount of research and trials that lead us in that direction. So when you see something having when something have a level of evidence C, that a lot of that is just expert opinion, and there's not a lot of research to so expert opinion and not a lot of research to back it up. Okay, when you see level of evidence B, then there's research papers to support what you're doing. Okay, if it has a level of evidence A, then there's tremendous amount of papers that is supporting that decision. Okay, all right. So when a patient presents with heart failure with reduced ejection fraction, when we did the epidemiology lecture, we said that patients who present with heart failure, the 5-year mortality rate is 50%. So that's a blanket statement. But we can risk stratify these patients. That is, we can determine to some degree of accuracy how well that patient is going to do. And we have the Seattle Heart Model to help us to risk stratify patients. So when you hear they talk about risk stratify patients, just to see how well the patient is going to do. In 1 year, what is the mortality rate? Or 2 years, what's the mortality rate? 3 years, what's the mortality rate? So a few years ago, we did the PRAISE trial, and this was a retrospective analysis of the PRAISE, and they look at 1125 patients, and patients with New York Heart Association class 3 and 4, EF less than 30%, patients who are on ACE inhibitors, patient diuretics, and there were 403 deaths. So they look at a number of things, and they came up with the Seattle heart failure model, and the risk that they identified. These are things that they plug in. So it is actually the Seattle heart failure model is not something that you can do by yourself. It's a program that you put these risk factors in, and it spits out the 1 year mortality rate for the patient. So you look at the age, the gender of the patient, what is the heart failure is ischemic related, yes or no, New York Heart Association classification, ejection fraction, systolic blood pressure, potassium sparing diuretics if they're using it, statin use, that is if they're using any of the cholesterol medicine, allopurinol use, hemoglobin, the lymphocyte count, uric acid. So there's a bunch of stuff you're going to put into this into this table or this online program, and it's going to give you the 1 to 2 year survival and 3 year survival. So I mean, you can download the Seattle heart failure model, and a lot of institutions, you know, the physician will download it and have it on the phone, and you just plug the numbers in, and it looks something like that. So with the Seattle heart failure model score, say a score of 0 means estimated 1 year survival of 96%. So, you know, excellent survival. But a score of 1, the 1 here, estimated 1 year survival is 89.5%. Score of 2, 74%. 3, 44%. 4, 10.8%. So this is much more accurate and useful. So you can individualize patients and determine risk. Because if the patient has a low 1 year survival, you're going to be very aggressive. I mean, you should be aggressive in all the patients, but you know, so it's actually it's a app that you plug in these the data, and it spits out the estimated 1 year survival. So it probably looks something like this, you know, the heart failure risk calculator. And you know, the diabetes, yes or no, COPD, yes or no, heart failure diagnose, yes or no, age and stuff like that. Um, you know, current smoker, New York Heart Association class, if the patient receiving beta blockers, yes or no, ACE inhibitors, the BMI, systolic blood pressure, creatinine, uh, ejection fraction, and as I say, you put this in the and put these data in, and it spits out the 1 year survival rate. Um, if you look at the you know, a few of the studies, the ADAIR, and this you know, this is floated around quite frequent. So you have to know what the acronym stands for. The ADAIR trial is Acute Decompensated Heart Failure National Registry, and what this registry tells us is that African Americans are associated with lower in-hospital mortality than whites. Okay, so even though they are at increased risk, the in-hospital mortality is lower than whites. Uh, in the emergency department, if there's a delay in measurement of BNP, that translates into a delay in treatment. Okay, so if it takes them a long time to draw this BNP, they're not going to treat the patient promptly. So, you know, they had your registry. So, in almost all emergency room at the present time, as soon as the patient lands, regardless what they come for, they're going to get a BNP. Um, and these delays were linked with modestly increase in hospital mortality. So also, what the ADAIR registry tells us that the positive cardiac troponin is associated with higher in hospital mortality. So those of you who are doing tests, once they talk about increased troponin, regardless what it is, if it's acute coronary syndrome, heart failure, it's always associated with increase in mortality. Higher the troponin, the worse the prognosis. Okay, so we went through all of that because everything, you know, what we do, everything we do is set by guidelines. Okay, and you can always pull down these guidelines and look through them. So we did mention a little bit about the class, and you're going to encounter this in reading your medical literatures. Okay, everything of a class and a level of evidence. So the American College of Cardiology Foundation and the American Heart Association guideline for the management of heart failure again, we have class of recommendation. Okay, and when we talk about class of recommendation, it's going to estimate the size of the treatment effect. It's going to estimate the size of the treatment effect, um, and it looks at the risk versus benefit. Okay, and again, you have your class 1 indication. If something has a class 1 indication, it has to be done. If you're sued and it has a class 1 indication and you didn't do it, you have no recourse because it is recommended. So class 1. And then class 2 is divided into class 2A and a class 2B. Okay? So class 2A, you probably should do it. Class 2B, you may or may not want to do it. And then class 3, if something has a class 3 indication, there's no benefit or there may be harm. So if you're sued and you did a class 3 indication, again, you have no leg to stand on. Okay? So you have to know what have a class 3 indication. And there are a lot of stuff that have class 3 indication. So you have to, one that comes to mind is patients with heart failure with reduced ejection fraction should never get calcium channel blockers like your cardizem and verapamil. That's a class 3 indication. Okay, and commonly you see patients on that. So if you do that and you're sued, you have no leg to stand on because studies have shown that those patients do poorly. So you have to know class 3 indication. All right, so we talk about the class and then the level of evidence. So the level of evidence can be A, B, or C. And the level of evidence estimate is an estimate of the certainty or the precision of the treatment effect. And we look at the rank of evidence supporting each recommendation. It can be A, B, or C. C recommendations are based on expert consensus. So A and B, you have a lot of data supporting what you're doing. C is just a bunch of guys who have been doing it for a long time, say it works, and it does work. So the recommendations are based on expert consensus and clinical experience. So it's a very busy slide where you can't see it, but this sort of point on what I was saying. So when you read guidelines, anything in green, it's a class 1. Green means go. You need to do class 1, have to be done. So if a patient comes in with an acute myocardial infarction, there are class 1 indications that you have to do. The patient should be on oxygen. You need to have two large IV lines in the antecubital vein. The patient should receive aspirin unless they're contraindicated to it. Patients should receive a beta blocker unless they're contraindicated. I mean, you have to know class 1 indication because those are things that you're going to be tested on. You may or may not be tested on class 2A or 2B. You'll be tested on class 1 and probably 3 because remember, class 3 indications are stuff that you should not do, which can harm the patient. So they want to make sure that you're not going to kill the patient. So they may ask you about class 3 indication. So the patients with heart failure with reduced ejection fraction, should you give that patient cardizem, yes or no? Okay, they want to know if you know that. So class 1, if you look in the literature, it's going to be green. Class 3, red, danger. All right, and then anything in between, shades of yellow. All right, so that's a class, and then we have the level of evidence. The level of evidence, A, B, and C. All right, so we gonna move on to we're gonna do a little bit of medical management, and so now I'm using my class and my level of evidence. So when you see I put something in bracket, it has a class 1 indication, and the level of evidence is, hey, this have to be done. If it's not done, it's malpractice. So how are you going to treat these patients with heart failure with reduced ejection fraction? So heart failure with reduced ejection fraction, beta blockers. Okay, beta blockers have been shown to reduce morbidity and mortality in these patients. Okay, it's going to reduce the risk of disease progression. So it's a good thing to do. It has a class 1A indication. Class 1 have to be done. Level of evidence is a A. So beta blockers. And all right, so all right. What I'm gonna, it's not on the slide, but I'm just gonna, there there are essentially two beta blockers that should be used. There are two beta blockers that have been shown to reduce morbidity and mortality in the multiple studies. And those two beta blockers are carvedilol and metoprolol succinate. Okay? There are numerous studies that show that these beta blockers not only improve survival, okay, they reduce, improve morbidity. So carvedilol and metoprolol succinate. Um, bisoprolol, um, in Europe, they use bisoprolol. We don't use it in the United States. Um, Rarely we use it. But bisoprolol was also shown to reduce morbidity and mortality, not to the same rigor as your carvedilol and your metoprolol succinate. Okay, and they so they use this a lot in Europe, but because it did not perform so well, we don't use it. So there's a cardiac insufficiency by bisoprolol study where the absolute mortality rate at 23 months was 16.6% for bisoprolol and for placebo. So they compared the placebo to the bisoprolol, and the mortality rate with the placebo was greater. But it wasn't, it was statistically significant, but not to any great extent. So that's bisoprolol. We don't use it, but it did show to reduce mortality somewhat. Metoprolol, they the MDC trial, which is metoprolol and dilated cardiomyopathy trial. I think this was a metoprolol tartrate. So then they look at what we call death plus the need for heart transplantation in 12 to 18 months was 12.9% for metoprolol and 20.1% for placebo. So you see, patients that were on the metoprolol tartrate this year, they fared much better. Okay, the need for heart transplantation or death was lower than with the placebo. And so in the MDC trial, the metoprolol did provide significant improvement in quality of life, ejection fraction, exercise capacity, but there were no difference in all-cause mortality. Again, as I said, this is metoprolol tartrate. So if you're given a question, which beta blockers, and this is a question that you get all the time, which beta blocker improves mortality in heart failure with reduced ejection fraction? It's only two beta blockers. I mean, you can say we don't use bisoprolol, but it is metoprolol succinate, not metoprolol tartrate, metoprolol succinate and carvedilol. Okay, so the metoprolol tartrate in this NDC trial, there were no difference in all-cause mortality. Did a lot of good stuff, improve exercise capacity, improve ejection fraction, and significant improvement in quality of life. This MERIT heart failure trial is different. MERIT heart failure trial, they use metoprolol CR or XL, the so-called metoprolol succinate, long-acting metoprolol. So this is a different animal. Long-acting metoprolol, metoprolol CR, XL, or metoprolol succinate. So it's a randomized interventional trial in congestive heart failure, the MERIT heart failure trial. So there was a mortality of 7.2% per patient year for metoprolol CR-XL and 11% for placebo. So, and this was significant. This was statistically significant. So you have a lower mortality rate with metoprolol succinate than placebo, and it reached statistical significance. And then the same thing when you look at carvedilol, okay? Mortality, if you look at if mortality is a primary endpoint in this study, the absolute mortality rate is 3.2% for carvedilol and 7.8% for placebo. You get a significant reduction in risk of hospitalization with carvedilol. And the Copernicus trial, where stands for carvedilol prospective randomized cumulative survival, there's a huge mortality benefit for carvedilol. So you don't have to go through all of this. What I'm saying to you is just 2 beta blockers that have been shown to improve survival in heart failure, because that's what they want to know. So I'll give you all this information. The patient should be on a beta blocker. It's a class 1A indication. Okay? The 2 is, if you're in Europe, then bisoprolol, or the Caribbean, bisoprolol, they use it there. I mean, if bisoprolol is on the exam paper, put it. If they have metoprolol tartrate, do not put it. It does not improve survival. There's no mortality benefit for metoprolol tartrate. No mortality benefit for atenolol. Okay? And the other beta blockers, propranolol and all those, no mortality benefit. The only 2 that has mortality benefit is carvedilol, metoprolol succinate. Okay, so another one, the bucindolol, so-called Bextra. I think this was banned in the United States. Anyway, no survival benefit for that, so it's not used. So when you look at beta blockers, meta-analysis of 15 trials, 3,023 patients. Beta blockers reduce all-cause mortality by 32%. It reduced combined risk of death or hospitalization for heart failure for 37%, and it increased ejection fraction by 29%. So beta blockers do a lot of good things in heart failure with reduced ejection fraction. So that's why it has a class 1A indication. All right. We're gonna stop here, and then hopefully next session